everyone. Welcome to this Lancet webinar where we will do the global launch of the Lancet Child and Adolescent Health series on racism and child health in the USA. My name is Esther Lau. I'm the editor-in-chief of the Lancet Child and Adolescent Health, and I'll be chairing this webinar today. The series of two papers were published in our February 2024 issue. The first paper is led by Dr. Natalie Slopin and gives an overview of the quantitative evidence of racial and ethnic inequities in the quality of pediatric care in the USA. The second paper, led by Dr. Monique Jindal, then looks more upstream at societal systems and explores the policy solutions to eliminate racial and ethnic disparities in child health. So over the next hour and 15 minutes or so, we'll have a short presentation of the two papers, followed by a panel discussion, a Q&A, and some closing remarks. Throughout the webinar, you are welcome to submit questions by using the Ask a Question box on the dashboard. You will also see a box with related resources, which will take you to the full series and related content on thelancet.com. You can adjust or minimize any of the boxes on the dashboard to suit your preferences. This webinar will be recorded, and a link to the on-demand version will be emailed to all who registered. At the end, please don't rush off and take 30 seconds to complete a feedback survey, and then please do go and read the papers. So before we get started, let me introduce our speakers today. First, we have Dr. Natalie Slopin, who is Assistant Professor of Social and Behavioral Sciences at Harvard T.H. Chan School of Public Health. As a social epidemiologist, her research focuses on the societal and contextual factors that shape childhood development and inequities in health. Dr. Monique Jindal is Assistant Professor of Medicine at the University of Illinois, Chicago, and practices as an internal medicine pediatrics primary care physician. Her research addresses racism at different levels and aims to inform both provider level and community level interventions that mitigate health disparities for minoritized populations, particularly those driven by racism. Natalie and Monique are the first authors of paper 1 and paper 2 respectively, and they will take us through the key messages of the papers. After that, we'll have a panel discussion, mainly focusing on the policy side of things, and I'm delighted to be joined by 4 other authors of the series. So we have Dr. Elizabeth Barnett, who is a pediatrician and associate professor of pediatrics at the University of California, Los Angeles. She cares for youth detained in the juvenile legal system in California and is also developing an intervention for young people after incarceration. We'll also be joined by Dr. Nia Heard-Garris, a pediatrician and assistant professor of pediatrics at the Ann and Robert H. Lurie Children's Hospital of Chicago. Her research revolves around the relationship between adversities experienced early in childhood and health, with a special focus on structural racism. We also have Dr. Nathan Chomelo, who is Medicaid Medical Director at the Minnesota Department of Human Services and Adjunct Assistant Professor of Pediatrics at the University of Minnesota Medical School. His work centers on the impact of early childhood intervention and healthcare access on the long-term prospects of our children, and how physicians and health systems can address racial and health equity. Finally, we also have Dr. Tiffany Johnson, who is tenured Associate Professor of Emergency Medicine at the University of California, Davis School of Medicine. Her research examines root causes of disparities, including racism in healthcare and society. So after the panel discussion, I'll bring all our speakers back for the Q&A, so please do submit your questions as we go along. And now I'll hand over to Natalie to kick us off with the presentation.
Great, thank you. So it's an honor to be here today to present on the first paper of this series on behalf of our team of co-authors. And this paper really was possible thanks to a range of experts that contributed across different specialties from across the country. So I would like to acknowledge the co-authors and thank them for their contributions. So the first paper of this series is focused on racial and ethnic inequities in pediatric care. And this topic has received increased research attention over the past 2 decades, and particularly in the past 5 years, alongside an increased societal focus on racism. So if we look at the publications that are coming out under the key phrases of racism and health, we see that there has been massive increase in interest in racism in children's health. And so in this series, the first paper summarizes the recent evidence that we have on racial and ethnic inequities and the quality of pediatric care. And what we have done is we've limited our review to recent studies that adjust for or stratify by insurance status to account for group differences in access to care. And we also have attempted to exclude studies where differences are likely driven by patient preferences or appropriateness of interventions as the primary reason for potential differences across these groups. So our review is both of the papers in this series are guided by an ecological model of racism, as is outlined in the figure that I'm showing here. So this model views racism as a multi-level construct that shapes child development via interconnected structures and systems. Here we're referring to systems related to healthcare, education, housing, and our legal and economic systems, as well as interpersonal relationships that are influenced by both implicit and explicit bias. And together, these systems and structures and interpersonal reactions contribute to possible sources of treatment inequities within pediatric care. So the overarching aim of this review, as well as the second paper in the series that Dr. Jindal will talk about next, is to highlight structural sources of inequities in environments that children experience. And here we're focusing on pediatric healthcare environments specifically. And so, as I had mentioned when I started, the focus of our review here is on inequities in healthcare. And we're highlighting differences that are related to quality of care, leaving out the topic of access for the present review. So we searched PubMed with the guidance of a professional librarian to collect studies that were published in roughly the past 5 years. So our search period was between 2017 and 2022. We included quantitative studies that were set in the United States. We used a broad range of ages within the childhood period. So we included children and adolescents less than 21 years. And our primary objective was to compare the study needed to have a primary objective to compare at least one healthcare quality outcome between one or more racial and ethnic group. And we required that the studies made some effort to adjust for or stratify by insurance status or restricted to a single type of payer so that we could partially account for access to care. And so in brief, our study revealed widespread patterns of inequitable treatment across this pediatric care specialties that we included. So we found studies within neonatology, primary care, emergency medicine, inpatient and critical care, surgery, developmental disabilities, mental health, endocrinology, palliative care, as well as some other specialties. And so overall, the identified studies indicate that children from minoritized racial and ethnic groups received poorer healthcare services relative to non-Hispanic white children, with most studies drawing on data from multiple sites and accounting for indicators for family socioeconomic position, as well as clinical characteristics such as comorbidities or condition severity. So these overall were quite high quality studies. Some of our key messages in the review are that, we find these patterns described on the prior slide, and there was quite a bit of evidence. There's different amounts of evidence across the different specialties, with some specialties having more consistent care than others. But overall, the message is that these disparities in quality of care exist. We concluded that the study designs used in the literature were generally strong, with many studies including multiple control variables for families' socioeconomic position and clinical characteristics. We noted an underrepresentation of studies that included Asian American and Native American children. So there are less conclusions that we can draw on differences in care for those groups. And we also note that while implicit biases and stereotypes were hypothesized as causes for providers' clinical decisions that shape disparities in care documented in these studies, there were few studies that empirically explored the role of implicit bias in relation to disparities in treatment decisions or outcome, suggesting an important direction for the future. So our first paper of this series concludes that policy changes extrinsic to the healthcare system are essential to address the upstream forces that create and perpetuate racial and ethnic disparities in children's healthcare quality, which is the focus of the second series of the review that Dr. Jindal will now talk about.
Sorry, I was muted. Thank you so much for having me here today. As Dr. Slopin alluded to, I will be discussing the overall conclusions from our second paper, which really focused on policies to eliminate racial and ethnic health disparities for children in the United States. So going back to that ecological model of racism, we can really focus our attention to the level of structural racism, so that top area there. And what we want to think about is that structural racism actually acts through policies within intersecting societal systems that perpetuate inequities in resource allocation and opportunities, which then in turn produce racial and ethnic health inequities for children. Within this paper, we focus on particular societal systems within the US, including housing, economic and employment opportunity, health insurance, and the criminal legal system. So starting with housing, when we think about how housing can impact a child's health, there are a few main areas to consider. So the first of which is housing instability, which can be defined as moving frequently or falling behind on rent. Housing instability has been associated with depression, drug use, and unintended pregnancy. The next area we think about is poor quality housing. That can refer to dampness within the house, poor ventilation, and overcrowding. And these types of conditions have been associated with asthma, poor cognition, and poor emotional functioning. Next, unaffordable housing is associated with less disposable income to promote a child's development and well-being. And then lastly, location of housing. Well, actually, where you live determines your access to education, nutrition, and healthcare. And so diminished access to these resources is associated with premature mortality. When we're thinking about how we might structure housing policies to improve child health, many call upon redlining within the US to explain these disparities. So redlining refers to a practice that started in the 1960s of categorizing neighborhoods as hazardous or unworthy of investment based upon the racial makeup of the neighborhood. What this led to was a systematic denial of mortgages in predominantly minoritized communities. However, there are many present-day policies that are responsible for limited home ownership and access to high-quality housing. This can be seen with unfair eviction policies, low home appraisals within minoritized communities, differential treatment during housing searches, and more. However, we recommend that if we focus on the social and economic conditions of segregated neighborhoods, we may be able to improve the health of children who live within them. So some examples of suggested reform that we recommend include community investment initiatives. This can look like giving financial incentives to organizations that have healthy food projects or that improve green spaces within a neighborhood. We also recommend protection for renters that are at risk for eviction. So this can look like the right to counsel or access to a mediator between both the person and their landlord. Increasing the stock of affordable housing, also increasing the amount of fair housing testing that's being done. So that refers to kind of the idea of using secret shoppers for rental properties or homes to determine if discrimination is occurring during those viewings. And then lastly, financial assistance for non-housing related disposable income. Moving on to economic and employment opportunities. The median annual household income for Black households in 2019 was about $45,000 compared to $76,000 for white households. Low parental socioeconomic status has been associated with low birth weight, asthma, depression, and antisocial behavior for children. When we think about how we might improve the economic and employment opportunities for minoritized families, we really want to consider how safety net programs can be altered. So safety net programs within the US might include SNAP, which is the Supplemental Nutrition Assistance Program, or TANF, which is Temporary Assistance for Needy Families. And a lot of these are structured with policies that are rooted in structural racism. States have a lot of control over these programs and can decide how much of their funds that they want to use on basic assistance. And they actually get credit if they have less cases or less families within their program, which can then incentivize penalizing families more quickly to get them off of their caseload. This is definitely being seen more and more frequently in southern states, which have larger numbers of Black families. So to improve the current situation, we recommend a few things. We recommend establishing federal minimums for benefits for safety net programs. We also recommend banning work requirements for programs. We are seeing that with the work requirements, families are being forced into finding immediate employment, which often leads them to finding jobs within sectors that are pretty low paying and perpetuates their time within poverty. We also recommend expanding paid and family sick leave. This has been shown to improve access to well child care, dental care, and flu vaccination. And lastly, providing reparations. There's a growing body of literature that really supports reparations for slavery to reduce health inequities. Moving on to health insurance and child health, Medicaid and the Children's Health Insurance Program, referred to as CHIP, cover more than half of minoritized children in the U.S. Children that are under these programs have improved access to medical, preventative, and dental care. They have greater use of preventative services, and they receive higher quality of well child care, all of which are associated with reduced hospitalizations, reduction in chronic conditions, and reduced mortality. Most uninsured children are in the 12 remaining non-expansion states for Medicaid. Non-expansion states are predominantly located in the South, where once again, about 56% of the Black population resides. When we think about insurance reform, we want to focus again on how we can reduce state level control, ensure continuous enrollment, especially for vulnerable populations such as postpartum birthing people, and improve reimbursement rates. I'm going to hold off on discussing reform further in this area, as Dr. Nathan Chomolo, one of the co-authors and panelists, will be focusing on this throughout the panel discussion. Next, moving on to the criminal legal system. A third of Black men are imprisoned in their lifetime in the United States. 1 in 1,000 Black men will be killed by police. Half of Black women have a loved one who is incarcerated, and 1 in 9 Black children have a parent that's currently incarcerated. Such racial and ethnic disparities are present in every step of the way in the criminal legal process, and they're all linked to adverse health disparities. So first and foremost, disproportionate police contact is associated with poor mental health, risky sexual behaviors, substance use, and heightened mortality risk into adulthood. Going beyond police contact, that initial contact, youth detention and incarceration is also associated with worse health outcomes, which may be due to the psychological and physical traumas that are endured within those spaces. Children who are detained are more likely to have undiagnosed and undertreated chronic health conditions. And lastly, incarceration influences the health and well-being of adolescents and young adults, even when they are not the individuals to be incarcerated. Young people with an incarcerated loved one experience feelings of alienation, adverse mental and physical health, and foregone health care. My colleague, Dr. Barnard, will discuss how we can really think about reform in this area given these profound health consequences. Lastly, we'll talk about immigration. So policies that control immigrants' access to resources exist all across all levels of government and within all social sectors. Exclusionary policies are associated with poor self-rated health and poor mental health. There are a lot of inclusive policies that are actually associated with better child health. So amendments to eligibility restrictions for food assistance and CHIP has been associated with decreased food insecurity. Deferred action for childhood arrivals has been associated with decreases in adjustment disorders and anxiety disorders. And then driver's licenses for undocumented immigrants has also been associated with decreases in some chronic health conditions. Thank you so much, and I will pass it over to Esther.
Great, thank you, Natalie and Monique, for the very helpful overview. Your presentations and the papers have really clearly laid out the many factors underlying racial and ethnic disparities in pediatric care, as well as the more upstream decisions and more macro factors that result in the inequitable allocation of resources through laws and policies. So as you mentioned, the series papers focus on 5 areas of policy: housing, economic and employment, health insurance, criminal legal, and immigration. And I'd just like to acknowledge that these are by no means an exhaustive list, and these areas intersect as well. In fact, I remember we had several discussions around what we could reasonably include within the scope of the paper. Anyway, so you wrote in the abstract of paper 2 that policy efforts that do not directly address structural racism will not achieve equity, and instead worsen gaps in existing disparities in access and quality. So jumping into the panel discussion, my first question for Nia is, can you give an example of policies that have actually worsened disparities and reflect on what we can learn from these experiences when it comes to future policy making?
Thank you so much, Esther. And I also would like to say thanks for having me and having this whole team here today. I think Dr. Jindal did an amazing job in talking about the different policies, whether people think they are directly or indirectly related to health. They are. You know, she talked about redlining, which was really, really important, and people are coming to understand the importance of housing and health. But there's some other policies too that we've seen the direct impact on health. One of the ones that we didn't necessarily highlight in this webinar, but we've done in other work, is thinking about how things like the war on drugs. So in the 1980s and the 1990s, which was a racial profiling and targeting of Black and Brown communities through excessive arrest and sentencing, incarceration for drug offenses, how that also contributes to this prison, the school to prison pipeline, the carceral system largely, in thinking about those people that are indirectly targeted by the carceral system are more likely, their kids are more likely to enter the carceral system. So mass incarceration affects over 5 million children whose parent that had lived with them have gone to jail or prison. And so that also impacts health. So we're talking about mental health, PTSD, anxiety, depression, and also physical health. So asthma, exposure to HIV, probably also COVID-19, we don't know yet, and many other things. One of the other policies that I'm not sure people really understand is the impact of green space. The importance of green space in health is becoming more elucidated within the research. But prior to 1964 and the Civil Rights Act, many racial and ethnic minority groups were legally prohibited from using national parks, national and state parks. And so that meant they could not engage with the beauty that is the United States and all over to access those, the Grand Canyon and other places. And so that has indirectly led to Black and other minoritized groups engaging with these green spaces less, right? And so we know that there are really good impacts of being outside, being in nature, for health and wellness, from physical health, including asthma, as well as obesity and all and other things associated with that. And so the use of those policies to exclude people or to directly target them has impacted health overall. And so those are two things that I would love for the listeners to think about, how those continue to perpetuate today: the war on drugs and the exclusion of Black and Brown people from national parks and green spaces.
Thank you, Nia. Well, I didn't know that about the national parks. So switching gears a little bit, I want to talk about access to healthcare and health insurance. So the Affordable Care Act passed in 2010 has enabled many families to access Medicaid and the Children's Health Insurance Program, CHIP. But we know that there are still many unmet needs. So I want to ask Nathan the next question, which is, what are the priority actions to meet these unmet needs, and how can we move towards universal insurance coverage for children and people who are pregnant or postpartum?
Yeah, thank you, Esther. And just wanted to echo thanks to our co-authors. Special shout out to Dr. Slopen and Dr. Jindal for leading this really impactful work. And so let's talk about some of those unmet needs first, right? First would be the number of uninsured. And so since its passage in 2010, the Affordable Care Act has helped cut the U.S. uninsured rate nearly in half, while having some significant impacts on reducing racial and ethnic disparities. But there still are notable gaps. We still, in 2022, had over 25 million non-elderly individuals who were uninsured. And that was roughly 9.5% of all non-elderly Americans. For children, we had about roughly 5% of children who were uninsured. And we know that that is not felt equally across communities. So there's racial and geographic inequities in coverage. When we look at children in particular, 12% of children who identify as American Indian or Alaska Native are uninsured, 10% of Native Hawaiian and other Pacific Islander children, 8% of Hispanic children, and then 4% of Black and white children, and 3.5% of Asian children. And we know that those who live in rural areas are more likely to have public insurance as well, and that the states that have yet to adopt the Affordable Care Act are predominantly in the southeast part of the country. And in 2021, 44% of low-income Black adults and 37% of low-income Hispanic adults lived in those states that have yet to expand Medicaid. And we talk about adults too, because we know that a lot of the gains in children's healthcare coverage actually come when parents and caregivers have coverage and find out that when they get their coverage, oh, their children are actually eligible, and that increases care as well. And so when we think about the fact that Medicaid covers more than 40% of births, over 60% of births in our Black and American Indian communities in particular, these inconsistent Medicaid policies really do contribute to the inequities we see. And then there's inequity in quality of care. So gaps in measures like immunization rates, dental care, behavioral health, mental health, well child visits. We know that they exist between publicly insured and commercially insured children, but then there's these gaps within gaps. And so as noted by Dr. Slopin and co-authors, both among commercially insured and publicly insured Black and Indigenous communities, we see gaps in measures based on a child's race or ethnicity. And we really haven't even developed the infrastructure to measure the experience of bias. And we know that that exists as well. So, what are some priority actions? And this is really based in evidence from the literature, what has been somewhat a natural experiment with the COVID public health crisis, and what communities have really told us for many, many years. So thinking about expanding access, decreasing administrative burdens, and greater equity in care and payment. When we look at access, we see that those states that have accepted the Affordable Care Expansion improved perinatal and maternal health, increased preventative care use, decreased incidences in things like child neglect and high school dropout rates, and nearly a 50% greater reduction in infant mortality, was a sharpest decline amongst Black infants. And in fact, we've seen states start to recognize this. So in the paper, we wrote 12 states, and since then, 2 more states have adopted the Affordable Care Act through measures that their communities asked for, South Dakota and North Carolina. And so we really do need the federal government to step up and ensure that everyone has access to the benefits stemming from laws of the land like the ACA. In addition, we have seen increase in access through postpartum coverage. And so we now have 41 states that have exercised the option to extend postpartum coverage to 12 months, which has real health equity implications. And then when we think about administrative burden, like Dr. Jindal noted, regarding work requirements, we see there's a lot of administrative burden around our public health insurance programs. And when we actually look across the population of all those who are uninsured, 25% of non-elderly are actually Medicaid eligible. Another 35% are eligible for tax credits. And COVID-19, again, taught us this lesson. We actually saw more than 5 million people gain coverage between 2020 and 2022 because of the continuous coverage policies that COVID-19 initiated. And that really drove down the insured rate to a historic low of 8%. And when we looked at children, American Indian and Alaska Native children, who we noted had the highest rate of uninsurance, saw the biggest increases. And so really, and another thing is that held true across states, whether or not they implemented the ACA or not, they saw these drops in rates. And so again, thinking about how can we reduce those burdens, how can we make it something across the country? And we see states now advancing multi-year continuous eligibility for children in particular. So Oregon was the first. There's 11 in total so far that are implementing or developing. Shout out to Minnesota, which is amongst those 11. And then lastly, greater equity in the quality of care via greater payment and resourcing. We know that low reimbursement rates limit access to quality care and contributes to poor health outcomes. There's evidence that increases in reimbursement rates by as little as $10 per visit have been shown to increase the probability that a Medicaid recipient reported a doctor visit in the last 2 weeks or reported good health. And so in addition to expanding healthcare access, we need to think about how we can increase reimbursement and cover services from culturally specific providers like doulas, community health workers. How do we improve the integration of screening and support for parents into payment models, all as a way to really improve our healthcare system for children and families. And then lastly, you talked about kind of moving towards universal coverage. And so, I think longer periods of continuous coverage, making folks actually have to opt out of publicly insured coverage are steps that we can take. But ultimately, a narrative change is really needed about what is the societal gain that is common sense and backed by an ever-growing research base of keeping kids healthy. And we're really, the United States is one of the wealthiest wealthiest countries in the history of the world. The fact that we can't guarantee our children access to healthcare is, I think, a real mark of shame that we need to work through. And when we look around the country, other countries have figured this out. And so the hope is, if we look at ensuring all our children, that can continue to change this narrative around health and really put forth that health should be a human right.
Thank you. Yeah, so right about the narrative change. And I think another area that requires like this massive narrative change is around incarceration, which again disproportionately affects Black families. As Monique presented earlier, the stats are really staggering. 1 in 9 Black children have an incarcerated parent, and Black children are detained at more than 4 times the rate of their white peers. This is deeply, deeply traumatic for families with intergenerational transmission of health and social risks. So the next question I want to direct to Liz. What are the key reforms needed in the criminal legal system and in other areas of policies to address this injustice?
Hi, thank you so much. Can you hear me? Can you hear me?
Yes, we can.
Okay, great. Well, thank you so much to the journal and to all of my co-authors and the leader of our manuscript, Dr. Jindal, because this is such an important question, an important issue to address. And I think we're all doing that first step for the policy change, which is recognizing that mass incarceration has a profound impact on children's health. And there are tremendous structural inequities and racism underlying the experiences of children. And so what is needed to address this? What reforms are needed? We need legislation that aligns with children's rights standards, particularly in the realm of children deprived of their liberty. So this includes legislation for a minimum age that children can be in the system, not incarcerating children with adults, and also policies such as no juvenile life without parole, recognizing that there is no such thing as an irredeemable child. Every child deserves a chance to receive support and thrive. And the main paradigmatic approach, we need to recognize the root causes of why children are coming to the attention of law enforcement. So what are the structural factors related to racism, and what aspects relate to the school to prison pipeline? One of the things I'd like to think about that I really believe can make a profound difference in the school to prison pipeline, our role in resolving it. So if you think, for example, about the issue of neurodiversity, this isn't something that child health professionals are really talking about, but the numbers that I've been looking at lately indicate that 60% of children in the juvenile legal system have dyslexia. A very large percentage have ADHD. And then there's, so probably the vast majority of kids in the juvenile legal system are neurodiverse, probably 90% or more. So really the question is, how do you pass policies that protects kids from coming into the system, policies that improve the conditions of confinement, and most importantly, get children the support that they need and deserve, and that, as Nathan said, is their right. Another important area I think that really deserves more attention is reforms around the quality of healthcare. So the juvenile legal system was established in the 1900s with the recognition that children need a separate place so that they can get help, not punishment. Right now, the 8th Amendment in the United States protects people from cruel and unusual punishment. And following from that, the Supreme Court of the United States has set the standard that healthcare in carceral facilities cannot be negligent. That is the minimum standard to which we are delivering care to children. So children, in my opinion, should be getting care at least as good as what is delivered in communities. And this is a very important way to potentially really shift trajectories.
Great, thank you, Liz. As you said, a vast majority of youth who are detained or affected by incarceration are neurodiverse, or they have they need special support. So thinking about clinicians, how can clinicians support families affected by incarceration or young people upon release from prison?
That is a really important question. So the very first step for clinicians to know how to support families, we need medical education on youth incarceration and the public health context of mass incarceration and the adult carceral system. So right now, there's huge variability in the United States in terms of which trainees get exposure to carceral facilities or even any didactic training. And so having curricular competencies, having American Board of Pediatrics questions is going to start to create that shift and educate the next generation of pediatricians to be able to care for families. We don't have any national standards on what families should be doing, what pediatricians should be doing to support families. But I think what is most important from having worked with children and families for many years is not to be judgmental. There are no standards right now on whether you should screen a child for involvement in the juvenile legal system. I think the most important thing is to develop a trusting relationship with the family and to be really attentive to what they need, to be very generous with referrals. If a clinician is caring for a young child who's coming home from youth incarceration, it's you think about what is the role of a pediatrician in the medical home. There might be some extra steps needed to ensure continuity of care, and the pediatrician should be there to support the young person in their transitions back to school, back to their social environment, and to any follow-up behavioral health care. And the last thing a clinician can do is to advocate. I think for too long, our field has gotten away with pretending this is really a hidden population. These kids are locked away, we don't see them, and we forget about them. There's 48,000 children in the United States that sleep away from their families every day because of the carceral system. And as a result of this being a hidden population and concentrated in certain communities, in minoritized communities, people forget, even pediatricians forget, that these are just kids. And when you give them the right supports, they will. So advocate. You don't have to be in a legal system. Just know you're patient. You can reach out to me. There are tools with the American Academy of Pediatrics. There's many great experts like Nia, who's here, who can offer support, but please speak up. Thank you.
Thank you, Liz. Like you said, pediatric clinicians can play a really important role in supporting these kids. I think another area is that often pediatric clinicians are seen as trusted messengers, and in the paper, you also advocate for pediatricians to be modelers of civic engagement. So I want to ask the next question to Tiffany. Could you elaborate on how clinicians can engage with patients and the caregivers to increase civic engagement?
Absolutely. Is everyone able to hear me okay?
Yes, we can hear you.
Perfect. Thank you so much for helping me navigate these technical challenges. Sorry, I'm not able to see the audience today. But Dr. Barnett really teed me up really nicely by ending her segment discussing advocacy as we think about civic engagement. So pediatricians, we're naturally child health advocates. We do it every single day, whether it's providing anticipatory guidance to our patients and families, or when we contact insurance companies to advocate for coverage of medications or testing that are needed by our patients. But when it comes to civic engagement specifically, the American Academy of Pediatrics has a number of resources that I'll ask the organizers share in the chat with you. One that I find particularly helpful is the AAP's partnership with Vote ER. So Vote ER has established and developed a nonpartisan civic engagement tool. So this includes a Vote ER badge that you can attach right to your ID badge, and it has a QR code for voters to be able to self-register. So you can log into Vote ER and you can ask for them to deliver one of those to you via mail, and you can attach it to your badge. They also have PDFs that you can screenshot and make the screensaver on your cell phone so that it's easily accessible. And Vote ER also has some really helpful tools for conversation starters, including just examples for how you can engage engage patients and families in a nonpartisan dialogue about voting. So I know that many of us are probably watching the primaries right now, and many of us have our eyes set on November 2024 and the presidential elections. But it's also equally important that we're engaging our patients and our families around local elections, which can just have tremendous impacts on the social determinants of children's health and well-being. So, for example, right here in Sacramento, where I live, our local elections are taking place in March on Super Tuesday. And so, like many of you in the cities that you live in around the country and around the world, some of the key issues that are impacting my local community are issues like homelessness and housing and community safety and gun violence. And, you know, Dr. Heard-Garris talked about the importance of the climate crisis and green communities and climate equity. We also think about education and economic opportunities. Dr. Heard-Garris also talked a little bit about the war on drugs. So one of the things that I consider when voting locally in California, where cannabis is legal, thinking about cannabis tax revenue and how my elected officials are going to plan to use that money to support community-based projects in areas that were really the most harmed during those racially motivated wars on drugs. So it's really important that, you know, even as we think more broadly about November 2024 and the presidential election, also encouraging our patients who are 18 and older and our families to really get out and vote in these local elections where their voices can really make a tremendous impact and a tremendous difference. And then once they're in office, we can also call our elected officials to task by showing up to our city council meetings or inviting our Congress people to share our expertise on issues that are impacting child health and structural racism. And so you may think like, oh, I don't really know how to communicate and how do I write an email and how do I craft my message around equity. So I'll also point you back to the American Academy of Pediatrics, who has lots of resources to really help you on your advocacy journey, including a digital health advocacy tool to really help you become more effective at being a child health advocate. So I'll have our organizers also drop some of those resources in the chat for you.
Thanks so much, Tiffany. I wonder if you could elaborate a bit more on how pediatricians can more actively take an anti-racism lens in their day-to-day clinical practice.
Thank you so much. I think that's a really great question. So I wish we had an entire hour just to talk about this alone. So I guess when it comes to your personal anti-racism journey as a pediatrician, the best advice that I can give you is that you really need to first do your homework. And so you guys have taken a really important first step by joining into this webinar today and by reading these two fantastic articles that are being published in this month's issue of the journal. But just like you're not going to become an expert on reading EKGs by attending one talk or by reading one article, you're not going to become an expert on anti-racism by just joining our webinar today or reading one or two articles. So I really encourage everybody who's listening today to really take responsibility for your own education when it comes to the history of racism in America and racism in medicine and how it impacts your patients, your colleagues, as well as general society. So again, I have lots of additional resources that we can drop in the chat for you. Two are a couple of articles that I published on the topic. One is on child health advocacy and your journey to anti-racism that talks a little bit more about, again, the history of structural racism in medicine and what we can do to advocate for that. And another great resource is an article, Anti-Racism, Black Lives Matter, and Critical Race Theory, the ABCs of Promoting Racial Equity in Pediatric Practice, that really kind of breaks down some of the key language and background that you need to understand in order to be better advocates both in your community as well as within your institutions. And then another couple of resources that we'll share, the Academic Pediatric Association has developed an anti-racism and diversity toolkit. And so I would encourage you guys to check out all the resources that are available there. And then the American Academy of Pediatrics has a newly published book called Untangling the Threat of Racism, a Primer for Pediatric Health Professionals. And several of the panelists participating today have chapters in that book, including myself and Dr. Jindal and Dr. Heard-Garris. And so as you take all of these tools and resources that we're going to share with you, and as you educate yourself on these issues that honestly have been historically and largely ignored in medical education, I also challenge you guys to really begin doing that internal work, right, of identifying the ways in which you personally have upheld structures of racism and white supremacy and making a commitment to being anti-racist. So this includes first beginning to think about what your personal biases are and exploring your personal biases and using evidence-based strategies to mitigate those biases when it comes to pediatric practice. But one of the important points that's been made several times in this discussion, so, a lot of my research has focused on implicit bias, but it's important that we acknowledge that we're never really going to achieve meaningful change by just focusing on individual hearts and minds and by doing implicit bias training. So it's really important that we also think about some of these more structural issues that have been brought up today. And so when it comes to your clinical practice, one way to address equity is through quality improvement work. So as pediatricians, we're all required to engage in maintenance of certification activities that include QI. And so one thing that you can do is by looking at your baseline and follow-up data and making sure that you're stratifying it by social demographic factors like race and ethnicity and language and insurance, so that you can evaluate the inequities and quality of care that exists right within your clinical practice. And perhaps one of the first places to start is exploring some of the many areas in which our first article has identified different inequities that exist in the quality of pediatric care and determine which of those inequities exist within your institution. And then it's really important to move beyond just identifying disparities, but really focusing on understanding what those root causes are and developing and testing interventions aimed at reducing those disparities. So when you're engaging in your QI work, it's really important that instead of just developing interventions that are centered around your most resource populations and hoping that a rising tide will float all boats, instead, how do you center your improvement plans around the margins, around the most vulnerable populations in your clinical practice, and recognizing that doing this is going to require partnerships with your QI analysts, with disparities experts who may be available within your institutions, but also centering and empowering the voices of families when you're developing your QI work and making sure that you're investing resources into that. Beyond quality improvement, another thing that you can focus on thinking at the larger organization level is looking at your institution, your department, your divisions, or for those of you who aren't in academics, even within your private practices, and start examining your local policies and procedures with an equity lens. So for example, some questions you can ask are, what insurers do you accept? And does that potentially result in inequitable access to state-of-the-art care that is being provided within your center based on the different insurers that you accept? Also think about things like, what are your late policies, and how do your late policies impact working parents who may live in transportation deserts due to some of the issues related to redlining that have already been discussed. So going back to that AAT textbook, Dr. Heard-Garris has a chapter in that book on using a racial equity policy tool to further anti-racism in pediatrics, and that's a great resource for you to begin looking at your policies within your practices and departments and divisions in your institution with a health equity lens. So those are just a couple of examples for things that you can consider within your clinical practice. For those of you who are on the call who are researchers, I would encourage you to collaborate with other investigators who are historically underrepresented in medicine, mentor trainees who are underrepresented in medicine, call out racism when you're reviewing articles when it comes up, and support DEI work within your institution. And then as we kind of round out thinking broadly around kind of those big academic pillars for pediatricians, we talked about advocacy, we talked about clinical care and research, but also just thinking about medical education. And so for those of you who are teaching students and trainees, I want you to really examine how race and structural inequities are portrayed within your clinical teaching. Make sure that when you're talking about different clinical areas that you're also mentioning some of these inequities that exist within those areas and providing your trainees with tools for addressing those inequities. So these are just a few areas that you guys can begin with as you think about how you can work on addressing and being an anti-racism within your clinical practices.
Thank you so much, Stephanie. And this really leads naturally to our Q&A section. So the first question is about medical education, which I will direct to Monique. So what would you recommend as the minimum requirement for medical education and training to ensure that future physicians have adequate training in health equity and anti-racism work?
Thank you so much for the question. I actually think Dr. Johnson almost kind of answered this question, but you know, I think there's some controversy about whether this education should be mandated or not, and you know, I stand in that it should be. I think if we only allow these educational opportunities to be given to those who look for them, we won't be reaching the entire population. We probably won't be reaching the providers that really need to get more of this education as well. And so I think, as Dr. Johnson alluded to, we definitely have to talk about implicit and explicit biases, but we can't stop there. So it's interrogating yourself, understanding your makeup, understanding your experiences that have led you to having these biases, creating spaces where other providers share their own biases so that there is a safe space to talk about working through them and moving through them. Understanding the literature that's out there that links biases to different treatment choices. And then also understanding the literature in health inequities and how they're rooted in structural racism. So pediatricians and pediatric education does a great job of talking about social determinants of health. And I would venture to say that most pediatricians are getting that training, but going a step further and understanding how social determinants of health are basically undergirded by structural racism and how those are linked inextricably is another area that really needs to be on everyone's radar who's getting pediatric education. And then also, as Dr. Johnson alluded to, just the historical and present day traumas that are occurring within the medical system. So how racism is embedded within our system is something that every pediatrician should understand. And then when you get outside of that, thinking about your workplace in general, I think we can talk to trainees about their own experiences of racism and discrimination. We can ensure that we have reporting tools, teach trainees about what those look like, how they can be operationalized. And then also, going a step further, Dr. Heard-Garris and a few other colleagues wrote a commentary on thinking about policing within hospital systems. So thinking about what that looks like within your hospital system, what the security system looks like, how that adds an added layer of trauma. And I think just educating every pediatrician on these many layers of racism that are embedded within our system. Everyone might not choose to be that fearless advocate and, do testimonials within the judicial system. We hope people will, but just having that understanding will make you a much better clinician.
Thanks so much. We have another question related to immigration. I'd like to direct this question to Nathan. Policies related to immigrants and their access to resources are often quite contentious issues. What would be your main arguments to advocates for inclusive policies for immigrants?
Yeah, thank you. Thank you for this question. I think plainly they're part of our community, right? We go to work with, we live next to, we worship with folks who are immigrants. I myself am the son of immigrants here in the US. And so I think particularly when we think about children, it gets to this idea and thing that we've lost track of, that, all children really should be our children. We should view all children as our children. Like we are really interconnected, and we can't, even if we make $1 billion tomorrow, we need other people to help live our fullest, best lives. And the way we get there is having children from the start, and their families have the support they need to reach their full potential as well. And when we think about immigration, we see that in even just the numbers as well. And so 20% of children in the US have at least one parent that is an immigrant. 12% of those have a parent that is a non-citizen immigrant. When we look at states that have recognized this, they've seen the benefits of expanding coverage to all children. So in states that have extended coverage to children regardless of immigration status, they found a decline in uninsurance rates, a decline in foregoing of preventative or needed medical or dental care throughout their populations, right? So we all, benefit when we really see ourselves as connected and all as part of one community. And then you can even just make some more harder number sense. The fact that, in 2018, it was estimated that undocumented immigrants contributed $20 billion in federal and $11.5 billion in state and local taxes. So they're here, they are paying their fair share, they're part of our community, and we really need to be able to see all children as our children for us to all have as much success and health as possible. Very
well said. Thank you. There's another question in the Q&A about child abuse. I wonder if Liz, you can take this question. So what kind of disparities do we see in terms of the kind of child welfare system, and what reforms are needed to ensure equity?
Yeah, thank you so much for this question. This is a very important issue. And I think when Nathan said earlier about the need for narrative reform around children getting healthcare, and how do we support children, there's this fundamental question of how do we support all children and all children with trauma, and the role of the child welfare system in meeting young children's trauma. The child welfare system is greatly in need of reform. It is overburdened, underfunded, and it has been demonstrated to be racist. In California, people have been exploring what's been called a blind removal process, which is where the child welfare practitioners make decisions about whether children will be removed from their home without having knowledge of the race of the child. And what they have found is that that actually has helped improved equity in the system. And I was actually just speaking yesterday, this is a very timely question, with the person who used to run the child welfare system for the state of California. And he explained to me the preliminary research that I don't even think it was formally researched at the time, that sort of eventually led to this approach. And what they noticed is when they drilled down on this issue of where is the racism creeping in, they found out that it was at the moment that the social worker was at the door of the family and talking to the Black mother, the determination was that the mothers were less trustworthy. And so these findings of how racism creeps into so many aspects of how people are interacting with families is so important, because this has such important implications for children's lives. So we need the child welfare system we need policies, just like Dr. Johnson said, that eliminate racism. And then very importantly though, so much of child abuse can be prevented by giving families adequate supports, by helping families have health care, by helping families live in healthy neighborhoods with green space, through poverty alleviating mechanisms. So we need to do the best we can to prevent child abuse, so that the child a much smaller role. And then we need policies within the child welfare system that are actively designed to address racism.
This is Dr. Johnson. Can I just add to that? Thank you, Dr. Barnett, for emphasizing the importance of thinking about this as kind of a broader child welfare policy area. But also, I want you guys to think about this within your own individual clinical practices, because, you know, as indicated in our first published article, when we think about all the inequities that exist within the care of children, child abuse is one of those areas where Black and Latine children are much more likely to be evaluated with a skeletal survey and with a head CT, even when their injuries are clearly accidental. They're more likely to be reported to the child welfare system. We're more likely to call social services and social work on them. We're more likely to call our hospital security and police on these families. So in addition to thinking about some of your local, state, and national policies, also think about within your institutions the roles that you are playing in contributing to some of these inequities, and the work that can be done in order to standardize care so that we are taking away some of our personal biases in how it's manifested in evaluation for child abuse for pediatrics.
Thanks so much, Tiffany and Liz. So final questions. I guess this one I would like to ask Nia. For people doing research in this area, what would you say are the main knowledge gaps and priorities? Yes, Nia, for you, please.
I can start us off.
Yeah, sure.
So at least within my research, a lot of my research focuses on medical education within the anti-racism space. And I think there's a big gap between our understanding of what these racism and racial bias trainings do for actual provider behaviors and how we can leverage them to decrease health inequities. And so there's a big gap between that. We know that there are a lot of positives coming from them as far as providers gaining knowledge, some of their attitudes changing, but that gap between understanding whether their attitude change will lead to a behavior change that will then lead to a difference in health outcome for minoritized children is still yet to be seen. So that is a big gap there. And then I can pass it over to another colleague.
Thanks so much.
This is Dr. Johnson. I can also jump in if Dr. Heard-Garris isn't available.
Yeah, sure, go on.
So if I'll pull directly from some of the recommendations that we included in our paper looking at the inequities and equality of pediatric care. So when it comes to research, we definitely are in need of more both qualitative, quantitative, and mixed method studies that really help us better understand how we can effectively intervene on what the drivers are for these inequities and medical decision making. So, we see that there are dozens upon dozens of studies showing that disparities exist, and there's still really a lot of research that needs to be done in order to understand what interventions are going to be most effective. Another gap that we identified is that when we think about what parents and children's experiences of racism in the healthcare system, there's still a lot of work that needs to be done in that area. And then when we think about different vulnerable and marginalized and underserved populations, I think based on some of the structural issues in the United States, a lot of our research has focused on Black versus white disparities or Black, white, and Latino disparities, but there's still a lot of research that needs to be done to understand inequities that exist for Asian American children, as well as Native American children, as well as multi-ethnic and multiracial groups within the United States and within our healthcare system. Other areas that we think about are intersectionality. So there's a lot of work that focuses on racism, but understanding that there are patients who are vulnerable and live at the intersection of many different identities, including race and gender, race and sex, sexual orientation. We talked a little bit about our families who are immigrants and come from that background and some of the inequities that exist for them, thinking about language proficiency, socioeconomic status. So there's a lot more work that also needs to be done on kind of the intersections of different vulnerable identities as well. And we also I think the biggest thing is we need evidence-informed approaches and policies that are to understand how our policies just systematically deny minoritized children and family access to high quality and equitable care. So those are some of the different areas for those of us who are researchers in the audience for how you can take your work and advance health equity.
Thank you. Nia, would you like to add anything to this question? I'm not sure we can hear you. Okay, in that case, we'll jump to the next and final question, and I think one for Nathan to answer. Quite a thought-provoking one. Are there specific strategies you would suggest to address racism while also addressing capitalism? Or do you think it's possible to effectively address racism without considering capitalism?
Yeah, such a great question. And I've started to be doing some thinking, writing about this. My own last year, I had a piece in Health Affairs that kind of asked that question: can capitalism actually address health equity? Right. One of the quotes I opened up with was actually from Martin Luther King, who said, capitalism is always in danger of inspiring men to be more concerned about making a living than making a life. And we see that the reason for that is that capitalism is about allocating resources and extracting value. And racism really is founded on also having resources for one group over another group. That's what it really was founded on, was the ability to justify institutions of slavery, of land theft, of colonialism. And so, I think if we are really intent on addressing racism, addressing health equity, we have to be real about what are the limits of a system that is, undergirded by capitalism, undergirded by generating wealth. And so what are the things that we all agree on? And that's why I think a narrative conversation is really crucial. What are the things we all agree on that everyone should have access to? And then, from there, we can see where there might be some benefits of innovation and driving forward change that capitalism can bring. But it really shouldn't be tied to delivering fundamental core health services in a way that acknowledges racism, acknowledges inequities. And so when you think about some of the strategies we talked about regarding, health insurance coverage, it's, ensuring access. Right? You need to be able to ensure access. Capitalism fundamentally doesn't ensure access. It's decreasing administrative barriers. That is making sure that you aren't putting up all these hurdles to essentially try to make something a scarce resource. And again, that feeds more into a capitalistic view of what healthcare's role is in our country versus one that is an undergirded right that we all should have access to. At the very least, our children should all have access to. And so I think there is a lot of overlap there. I really appreciate the question because I think it's something that folks in really kind of progressive spaces and lenses can, really overlook and think that they're able to put forth ideas if they don't consider what is the underlying push. How are things getting paid for? How are we allocating resources? How is that tied to capitalism? Then we are going to kind of keep spinning our wheels and not actually make the progress that we say we want to make and the progress, more importantly, that our communities need.
Great. Thank you so much for sharing your insights and experiences. I think we can keep talking about this for a long time, but we do have to wrap up. So I hope, Nia, you're connected now, so I'll hand over to you for some closing remarks.
Great. Can you confirm that you can hear me now?
Yes, we can.
Oh, thank goodness. Apologies to the audience and my teammates for the tech issues that I'm having today. We have talked about so much. Dr. Slopin led us off in talking about the relationships between structures and systems and interpersonal interactions via implicit and explicit biases that drive disparities in care. From birth to death is really what we saw, that there are disparities in health and healthcare for the youngest members of our society. And that can be completely overwhelming, not only to patients and families, but also to the pediatricians and the folks that are in the system that, signed up to make care better, to make children better, to make our world better. So in neonatology, we saw that there are avoidable and serious moderate complications for the littlest people in society. In primary care, Black and brown youth are less likely to get the vaccines they need that even prevent cancer. They're overscreened for sexually transmitted diseases or infections. In the emergency room, they're getting extra workup for child abuse and not enough pain medicine when they're in extreme pain for appendicitis and surgical needs. In the ICU and surgery, minoritized people are less satisfied with their care, and they should be, because in surgeries, we're seeing that they're having more complications post-op. So after surgery, more problems. They're having less counseling about their medications and safety and less likely to receive needed medications or services even for disabilities and ADHD and all the things that they need. And unfortunately, our sickest kids, the ones that are receiving palliative care, are more likely to die in the hospital and in fact, they may prefer to die at home. So there's a wide range of disparities that we see from birth to death, and it's not just adults, it's our littlest members of society. From a policy perspective, Dr. Jindal talked about how affordable housing access, economic policies, including banning work requirements, and even reparations could help to narrow these disparities and march us towards health equity. We talked about racial disparities in incarceration and immigration, and these are really important and timely issues, especially right now when a lot of cities are having more immigrants and more newly arrived Americans than they have had ever before. So how do we make sure that we don't exacerbate these disparities in 2024 and beyond? There is so much work to do. Many of us on this call love and admire Dr. Angela Davis, who said, "I'm no longer accepting the things I cannot change. I am changing the things I cannot accept." So with this question, we're faced with, where do we go from here? We've told you really, really hard truths about the state of healthcare and healthcare treatment for pediatrics. And, these are the next generation that's going to help to make our world better or worse. So we need to make sure that they're healthier. So what should we be doing? What, from a patient standpoint, all the way to society and communities, what does that look like? And I'm so grateful for every single person on this call, because we covered a lot of where do we go from here. We didn't end it on these are the disparities we should be sad about and not do anything about. This is what we should do. So I'm going to touch on just from every sort of aspect, any decision maker, any person that's a part of the system, what we can be thinking about and doing. So from a patient and family standpoint, the burden should not lie on patients and families who are in the system, oppressed by these systems, and are faced with the brunt of racism and inequities in care. But patients and families are not powerless. So I would use the power that patients and families do have to promote health equity. So families can consider getting involved in patient advocacy groups and pushing for better health care and health equity. A lot of the things that have changed in medicine have been because patient advocacy groups have demanded that they've changed. For example, work hours and making sure that you don't have a tired physician or a tired surgeon, operating on you or providing care is why a lot of these things change. And so there's power in that. There's power in advocating, demanding, expecting that your care is better. There are many advocacy groups, too many to mention on the call, but the Center for Black Health and Equity, the National Alliance for Hispanic Health, the Center for Asian Health Equity are places that you can start. Activism and advocacy, I would not underplay the value that those have had in changing not only healthcare, but really our society at large. Some of my work, my new work has moved towards activism. And how can activism not only help the individual, like for mental health and maybe even physical health, but really how does it help communities and how does it help societies by pushing, demanding, expecting better? So I think starting there for patients and families is a good way to promote health equity. From a clinician, hospital, clinic, healthcare system standpoint, disparities, even though they don't always start within the walls of healthcare institutions, they can and are often exacerbated by these institutions. And as Dr. Johnson already discussed, clinicians can do very deep dives in education and learning about the roots of segregated and racialized medicine. They can examine and reflect on how this shows up in their practice and in the group practice or the hospital practice or the clinical practice. So what does this do? How does this translate into who can even walk through your doors? What insurances do you accept? How much time do you get for patients that speak other languages than English? Thinking about the ways in which it's small or big that we discriminate and segregate care depending on who comes through our doors. Hospitals themselves have a duty to review and change their policies that create and exacerbate these inequities in care, these inequities in access, and equities in opportunities. These healthcare systems should review their own data by specialty and maybe even by disease process or by group, especially those that are the most marginalized. So thinking about people that don't speak English, people that may be undocumented, people that are Black and brown, and everything in between. Because we know from our two papers that we are not where we should be in 2024. And if we're not careful, we'll still be here in 2030, in 2050, in 2070. So it's really important that we take all the data that we collect through EHRs and other means to analyze that and actually create actionable plans to minimize and reduce and eliminate those disparities. There are ways in which we can partner with other institutions, with other nonprofits, with other government agencies that can help us do this, that are doing it or have done it before. So I would urge people at this level to take a look at the National Collaborative for Health Equity and working on their advocacy arm as well as their research and analytical arm, ensuring especially that the one minoritized person person that's in your clinic, that's in your hospital, or on your staff or your team isn't your only and isn't your last. How do you think about creating pipeline programs or pathway programs, or programs that not only help the people that are within the walls, but the ones that may never enter the walls, the ones that need to enter healthcare from a workforce standpoint? But because of their circumstances, the communities that have been disinvested in, those that have not have good opportunities and access to education and access to all of the things that they need to enter healthcare careers, what are you doing at that level as a hospital or a healthcare system to ensure that these opportunities are more equitable, so that not only your workforce but healthcare as a whole can improve and welcome people that have been historically excluded from these jobs? So one way to think about this is work that Dr. Jindal and Dr. Johnson have done. They wrote a piece about this exactly. Whether you're a pediatrician or not, whether you're a healthcare administrator or not, I think it's worth reading. It's called Getting Our House in Order, Rebuilding Academic Pediatrics by Dismantling the Anti-Black Racist Foundation. They write and elaborate on making pediatric practices anti-racist, so identifying and eliminating disparities, acknowledging bias, changing policy, increasing visibility, and the like. For researchers, especially us on this call and those that are not on this call but should be, our job is to bring the truth to light. We need to study and try to explain phenomenon. Some of us will create interventions to make the current state obsolete and move towards the ideal state. Again, Drs. Jindal and Johnson go on calling for the diversification of research teams and naming racism as the underlying problem for these disparities. Too many times we have blamed genetics for disparities. We blame access alone to disparities. We have not been willing to say the hard thing, to do the even harder thing, is to name racism and to try to work to eliminate it. We need to do that. It is more important now than ever as our healthcare system, as our society becomes more minoritized, right? We're talking about race and ethnic minorities, but they're growing fast and making up the majority. So if we don't heal and if we don't help the people that are in our society now, we will go on to be a sick society. And then finally, from a communities and society standpoint, again, there is strength in numbers. I would, encourage communities to think about forming or joining existing coalitions around health equity, to Dr. Johnson's point, to support the most marginalized members of the communities, not the most vocal, not the most wealthy, not the ones that show up every day for voting, but those that are marginalized, those that are in the shadows, those that are invisible, right? Those are the people that need our care. Those are the ones that need our voice. And those are the ones that should be at the table helping to make these decisions as well. As we close out, I have so many thank yous to give. I would like to thank the Lancet for this amazing opportunity. They saw a need for this work. They're highlighting the importance of disparities, inequities, and racism explicitly within pediatrics when so many others are scared, especially at a time like now when there are many attacks on talking about racism, talking about privilege, talking about disparities, talking about critical race theory. They have stepped up to the plate and allowed us to share this with you. So I'm incredibly grateful and thankful to them. I am also incredibly thankful to Dr. Monique Jindal and Dr. Natalie Slopin. Without their tireless work and effort, none of this would be possible. These review articles took almost 2 years to write, and they were diligent and continue to push us forward in times where it was really, really difficult. But our entire author team, I would encourage everyone on the call to look at all of the authors because they're all health equity stars in their own right. We've got medical students, we've got graphic designers and artists, Andrew Chang, Nessa Bryce, Aaliyah Bate, Andrea Fawcett, and then Drs. of course Johnson, Anderson, Clark, Cohen, Jindal, Carabia, Pachter, Priest, Suglia. That's on the review paper. And on the policy papers, of course, all of our panelists today, Drs. Barnard, Chimilo, Gilpin, Clark, Cohen, Crooks, Kershaw, Backus, Cozumel, Mistry, Schlaffer, Slopin, Suglia, and Winnemy, TPIO. We have so many people that made this work possible, and I would be remiss by not thanking them, as well as the media who have picked up this work at a time, again, where it is not safe to do. It is not always easy to be the voice of health equity. It is not always popular to talk about disparities, to talk about racism, to push this work forward. And there are many people that are allies in the media, that are allies at our institutions and beyond, that keep promoting this work and understand the importance of it. And then most importantly, for all of y'all who showed up today, thank you so much for being here and learning more. And hopefully it won't end here for you. You will continue to help us to spread this word and to do the work that is required. So with that, thank you for joining, and I will pass it back over to Esther.
Thank you, Nia, for this really powerful summary and the call to action. It's so important that we move from data to action. So once again, I'd just like to thank our presenters and panelists, Natalie, Monique, Liz, Nathan, Nia, and Tiffany for all your participation and all the hard work that you and the other co-authors put into writing the series papers. So please, please, please do click on the related resources to read the series papers online. I hope you've enjoyed this webinar and found it inspiring and helpful. And before you go, please do take 30 seconds to fill in our feedback survey. Thank you again and take care.